Ladies and gentlemen, please welcome back to the stage your conference chair, Anita Anand.
Hello, hello, hello. Nice lunch? Everybody have a good lunch? Lots of things to chew over as well from this morning's session. So those of you who might have missed it, I'll just do a very quick recap for you. It's quite a challenge, I think you'll all agree, facing these new 44 STPs. They're going to have to join some really very serious dots if this 2020 milestone is to be reached. And also there was a question mark hanging over whether that 2020 date was a policy or an aspiration. So what are they going to have to do? They're going to have to unite disparate tribes within the NHS, as you don't need me to tell you, have developed fiefdoms who are very proud of their territory and perhaps are not that used to this new way of thinking, this new way of working together. The STPs are going to have to make that work. As we heard from Howard Bernstein, there just isn't an option. It has to be done. But we also heard about some of the challenges that throws up. There are cultural gaps between some of these tribes. There are also huge financial gaps between some of these tribes. One of those which was the most stark that we looked at was the gap between social care and the NHS, where you have one side feeling the other side has been given vastly preferential treatment and feels quite cut to the bone, and you have the other side relying on them more and more to make these deadlines a possibility. So let's talk a bit more this afternoon about those dots being joined. Now, you heard Stephen Dorrell, he talked a couple of times about our next speaker this afternoon, who is the New York Medicaid director. And he was given this position in 2011. He's responsible for the care of over 5 million people. I read in my notes, every so often, I honestly, sometimes it may not look like it, but I do research, and I looked in my notes and it said that he handles an annual budget of $54 billion a year, which is about half what the NHS spends every year. So I asked him, I thought it was a typo on my paper. I said, this cannot possibly be true. And he said, no, it's not true. And I thought, thank goodness, it sounds ridiculous. He said it's 62 billion now. So this is a man with serious bucks in his pocket and a serious amount that he has to deliver with it. Please welcome to the stage the Director of New York Medicaid, Mr. Jason Helgerson.
Well, thank you. It's a pleasure to be here today to talk about New York and some of the things that we're doing on the other side of the pond. I'm honored, actually, to be here to talk about our redesign efforts in healthcare. I think there's a lot that can be learned across nations, and I think we spend far too little time talking to each other, because at the end of the day, a lot of the challenges that you face in whether you're in Manchester in England or in the Bronx in New York City are actually quite similar, and I think that there is, as I say, a lot for us to learn from each other. So with that, a little bit about our program. As was mentioned, it's about actually over 6 million people now enrolled in the program. The reason for the growth in the budget is the Affordable Care Act, also known as Obamacare, which expanded access to more and more Americans. And we have really thrived under that particular initiative in New York State. In addition, we do spend $62 billion for the second largest Medicaid program in the country, which makes us roughly the 5th largest entitlement program in the nation when you take into account also the programs that are run by the federal government. We are a public payer in what is predominantly a private healthcare system, although I would caveat that to say that American healthcare, while we typically, or people around the world typically think about it as a private system, it's a unique private system in the sense that it's dominated not by for-profit entities, but actually by not-for-profit entities, many of which are religiously affiliated, which actually creates a unique dynamic, not your typical economic actor in a free market situation. And then lastly, as a program, we serve a wide array of patients from the oldest to the youngest, wide array of services, including some of the social care services that you talk about in terms of trying to integrate them here within the United Kingdom. A lot of those programs and services already are part and parcel of our budget. So in terms of understanding where we're going with the program, and I think any jurisdiction that's going through a reform period, it's never done in a vacuum. It is done in a context based on your own particular history. Our history is that when my boss, the governor of New York, Andrew Cuomo, took office, he inherited the worst budget situation in state history. He was looking also at the largest element of his budget, which was the healthcare component, growing at 13% year on year at a time when his budget director was telling him to expect a decline in state revenues. That is not a recipe for fiscal success. And out of that created an absolute necessity in a sense that really the program was not sustainable. Also in that environment, we were walking into an environment where the program was sort of the ultimate sort of political football of New York State politics, constantly be batted around, very little reform actually moving forward, very divisive issue, and in fact a program some thought was unmanageable. And that made the environment very challenging, and many felt that our reform efforts would not be successful. But also our statistics, despite our huge level of investment, did not suggest we were doing very well. In fact, while you could measure us in some ways as sort of middle of the pack compared to other states, when you actually looked at us in terms of avoidable hospital use, which is a key measure which I think looks at not just hospitals, but overall, is the system doing well to get patients into the services that they need in the most cost-effective manner possible? And the answer to that question was a definitive no. We ranked 50th, dead last in the country. That means despite the fact that we're one of the wealthiest states in the country, we were performing worse than states like Mississippi, and that never goes over well in the state of New York. So what was the response? The response was the governor said, okay, you, the stakeholders, the people who represent the providers as well as the patients in this large and diverse program that's so vital to the needs of the populace, what do you think should be done to make this program sustainable? The past, the status quo is not defendable. We must move forward. And he gathered 27 representative individuals from that diverse group and tasked them with a plan, basically to put together a plan to achieve both initial budgetary savings in that difficult budget environment and to put together a multi-year plan. Despite many who felt that it was not possible, they in fact accomplished it, and they developed a 5-year action plan, which we are now in the process of implementing. We also were doing this within the context of the Affordable Care Act. The Affordable Care Act actually was implemented. Its main functions, the efforts to reduce the uninsured in our country, were done beginning in January of 2014. So we knew that was coming at the time we started this, and we wanted to stay consistent with it. But the key thing, and I think one of the things that we think is most successful, is we decided on a policy direction in 2011, and we have stuck to that to this day and anticipate moving forward with it as well. So what were the elements of our reform strategy? First and foremost, we needed fiscal discipline. This was a program where there were about 14 different individuals in state government alone who could make decisions and drive expenditures. No one was responsible for managing it, really. If it had a good year, great. If it didn't, we'd bring the legislature back and say there was a crisis and make reductions in the program, cuts to provider payments, other service restrictions. And so we created what was called the global spending cap. And as I've learned a little bit more about what's being tried through devolution here in Manchester and being considered and looked at in other places, much of what we've had to do over the last 5 years of managing the program within this cap has been, really an illumination for us. We learned so much more about the program. It's injected tremendous transparency out into the world. We report out on a monthly basis. But I think overall, that discipline and knowing what our expenditures are going to be in future years has been extremely helpful. Also, care management for all. We wanted accountability. We wanted individual organizations to be accountable for making sure patients got the services they need. And so we've been rolling out a series of programs under that rubric. Also, investments in primary care. Our big belief is at the end of the day, the primary care provider must be the center of the delivery system and must have the resources, knowledge, and connectedness to the rest of the delivery system in order to be effective, and we've invested in that. And then lastly, and I think perhaps most importantly, is we crossed the Rubicon relative to the importance of the social determinants of health. At the end of the day, complex patients, especially low-income complex patients, oftentimes have social needs that trump their health care. If a person with diabetes is living on the street, there's no way for them to manage their disease. Why? Because there's nowhere for them to put their insulin if they're living on the street. And without that insulin, without that ability to manage the disease, guess where they end up? They end up in the emergency room over and over and over again. And in order to address those challenges, we had to take on housing, we have to take on employment, and we have to be willing to see the broader picture and the challenges of the populations we serve. So our results to date, first and foremost, we have in fact made the Medicaid program in the state of New York sustainable. We've done that through a whole series of initiatives. In much of our first couple of years of reform, we're really focused on changing policies within our program, our payment policies, to make ourselves more cost effective. What this chart shows is basically for the first few years, we flatlined the overall expenditures in the program. And you see beginning in 14, the significant jump up, that's the Affordable Care Act, 750,000 individuals added to the program. But actually, even before the Affordable Care Act, we began growing the program. Why? Because the economy was weak, more people lost their jobs, they needed insurance through our program. And because we've held it flat, and but at the same time increased enrollment by over 1.5 million people, the only way the math works is you have to reduce your per recipient spending. And that's exactly what we've done. We now spend in our program less than we spent in 2000 on a per recipient basis. And that, I think, is also taken into account. People will ask, well, does that mean poor quality? Do you restrict services? We didn't take a single benefit away from a single New Yorker in order to achieve this result. We did this through more efficiency and better outcomes for the population. And in fact, we've been measuring quality in our program dating back to 2001, and we can show a clear line of improvement throughout the period, including during some of our cost containment periods. And that's why I'm a big believer that at the end of the day, especially if you look at it over even a short to mid-term horizon, you actually can achieve savings in a healthcare program and do it not on the backs of the patients you serve. So, in terms of next steps, at the end of the day, what the realization that we came to is, while we're a payer, and we are the largest payer, about a third of all healthcare dollars in the state of New York are coming from our program. At the end of the day, we can do a lot to make ourselves more efficient, change our policies. But if the delivery system we are purchasing from is less efficient than we need it to be, we are going to be limited. And in some ways, when we decided to move into this next phase of delivery system reform, we almost got into the business that all of you are in here in the National Health Service. What we decided was that we, as the government, had to take a more affirmative step to drive the system towards greater efficiency, and that's what we've been doing with what we call the Delivery System Reform Incentive Payment Program, or DSRIP. Now, it's not my name, it's the federal government's name. If I had to, I'd come up with something a little sexier than DSRIP, but that's what it is. But it is a $7.3 billion initiative, and that's new investment capital on top of our normal dollars that we spend in healthcare, and we see it as an historic opportunity to really address some of the structural changes, to rebalance the delivery system so we rely less on institutional care, hospitals, and nursing homes, and more on community-based services, which we know are more cost-effective. So what's the delivery system? What do we want it to look like? What are our aspirations? This is a 5-year initiative. We're basically in the early stages of the second year. It takes us to the end of the decade. So basically what we want are these words on this slide. Although these words oftentimes are used around healthcare, and I think probably used around the world in healthcare. But to us, they do have great meaning. I mean, obviously, we want a patient-centered delivery system. Why? Because at the end of the day, we need the delivery system, the providers, to really configure themselves to meet the needs of their community. And not always does the traditional way in which healthcare is provided is consistent with that. Also, we want much more transparency. We want collaboration. And I think, as I heard the introduction in the remarks from earlier today, this idea of collaboration is not easy in healthcare. Sometimes there are serious trust issues that exist across the various silos in the delivery system. And to a core, what we're trying to do is create collaboration, create cooperation amongst providers who, in many cases, used to see each other as competitors, direct competitors in the marketplace. And that's really a challenge, but I think an exciting opportunity for us is to get more of that sense of collaboration occurring. Next is accountable. Very little money in American healthcare is actually linked to outcomes. We're fundamentally trying to change that. We want the vast majority of the dollars not to be based on did you provide a service, but did that service actually improve someone's health and well-being? That's a major change in thinking in the United States healthcare system, and we're doing it in the largest payer across the fourth largest state in the country. And then lastly, value-driven. And this, I think, gets into beyond just healthcare. Healthcare providers are uniquely situated in communities, and I suspect this is the case in many communities in the United Kingdom as it is in many communities in New York and across the United States. Healthcare is a major employer. It's a major community partner. And as a result, I think is uniquely situated to actually drive things in public health and other types of initiatives that broadly will look at what can we do to improve the health and well-being of communities, and that's what we talk about when we say value-driven. So what is our structure? How are we going about this delivery system? How are we going to create a delivery system consistent with those tenets? So our structure is what we call performing provider systems. For some of you familiar with the word accountable care organizations, I would call this an accountable care organization designed basically around the needs of the most complex patients one could ever imagine. This organization, which were created, wholesale new organizations created all across our state, there are 25 of them in New York. Those organizations are made up of hundreds, if not thousands, of different individual organizations from across the entire spectrum of healthcare delivery, every type of population one could imagine, every type of service provider you could imagine, including those who are best positioned to address the social determinants of health. In our case, we call them community-based organizations, are all part and parcel of these collective efforts. A huge effort to really achieve collaboration, integration on a scale never tried in the United States before, and that's at the core of what we're trying to do. Each of these organizations has a goal, which is a 25% reduction in those avoidable hospital use, and a series of other measures based on individual projects they selected. But a huge effort, and it really a very much work in progress, but we are already beginning to see some pretty exciting success stories. So what are the PPSs, these organizations that have been created? What are they trying to do? What is their approach to system transformation? First and foremost, in the United States context, system in healthcare usually means a hospital system, a single employer who has a series of sort of horizontal and vertical integration elements that means that they provide a wide array of services. Really what we're trying to do is actually create a system sense of healthcare that looks across an entire community and looks holistically at the needs of the individuals who live in that community. It tries to bring in organizations who have expertise in criminal justice, education, public health, the social services, the social welfare services that are essential to meet the needs of the population. Get all those organizations working together with a common set of goals, common set of metrics, and giving them the flexibility from a funding standpoint to fund things that maybe traditionally wouldn't have been paid for within the healthcare context. So obviously for those systems, quality is at the top. All of the payments through the district program are linked to outcomes. It's not about effort. It's not about incurring costs and providing services. It's about, did you actually achieve a performance metric? And if you did, that drives payment. Key populations. The whole population, yes, there are certain initiatives that need to look at those populations, but also you need to look at a more granular level and design initiatives specific to subpopulations. Investing in primary care. I put it in the middle of this pyramid. Why? Because it really needs to be a centerpiece of the initiative. We need to not only support and expand access to high-quality primary care, but we ought to make sure it's integrated with the rest of the delivery system. Next is systemness, and this is, I think, not necessarily only unique to the United States, but as I said, we don't think of systems in healthcare all that much in the United States, but we also, I think, need to think across these sectors, across the human service sector, across the K-12 education sector, across other sectors, the criminal justice sector, because at the end of the day, each of these sectors is in essence seeing the same individuals, the same families, and we oftentimes don't talk to each other, don't work together, and we have to think more widely as a system. And then lastly, there is the social determinants of health, which really at its base is what needs to be done. It's the Rubicon we've crossed, and we believe fundamentally that it must be part and parcel of everything we do. So the other piece of this is aligning the incentives. A key part of our initiative, and part of this is the American context, but I think you could obviously put it in the NHS context, is we want the providers to actually have a financial incentive to actually work together and achieve better outcomes. We always talk about it is that we want the margins of these providers, some of whom are very financially fragile, to improve when they do better, when they actually better serve their community, when the value that they provide in services actually improves. And so we are in a rapid path that by the end of the decade, 80 to 90% of all of our reimbursement that goes to providers, of that $60+ billion is going to be value-based. To give you a flavor of where we are today, about a quarter of what we spend is value-based. So that means tens of billions of dollars moving into value-based types of contractual relationships over the next 3 to 4 years. So one other strategy that I think can apply in any setting, in any country in the world, and that is the concept of actually trying to empower providers at the point of care to actually do things differently than they do today that leads to better outcomes. Creating a process, in fact, a culture around continuously looking to improve how you provide services, not only within your organization, but across the organizations who all work with you and in essence see the same patients. We call this rapid cycle continuous improvement. Some of you may be familiar with concepts like Lean or Lean Six Sigma. It takes a variety of different forms, but the concept really is very simple, which is you get a group of providers together at a very local level, individuals who work directly with patients, who see where the problems in the system, where elements of the system begin to fail, and get them to actually map out those processes and identify opportunities to make those processes work together to help patients better navigate the system. And our experience to date with this has been amazingly powerful, is that when you actually empower with data and support the real frontline people of the healthcare delivery system, they will change. Why? Because I'm a firm believer, at the end of the day, people got into healthcare because they wanted to help people. And they get frustrated every single day with the elements of the system that fail and break down, and they would love to have an opportunity to make it better. And I think that's what we're pushing harder than almost anything else, is for these large 25, hundreds if not thousands of organizations within a performing provider system to take this concept and spread it all across their delivery system and empower those local providers. It's actually an amazingly wonderful thing to see. I always say that this is really watching the district program actually become reality, is watching these clinicians working together as interdisciplinary teams. We help to facilitate it, create a process to help them, but it's not the state or the government or anyone dictating what the right solution is. We are empowering them to make changes in their own processes that they can impact and give them the data to show whether what they're doing is successful. So far, we focused this initiative on individuals who have, we call the super utilizers, individuals who are in and out of emergency rooms 20, 30, 40 times in a year. And what we found is really significant results. Somewhere between 21 and 44% reductions in ER utilization in the targeted population. And it's really identified for us some of the key, even public health challenges. And for instance, in the United States today, one of the biggest challenges we have is the opioid crisis, where we have far too many individuals who are addicted to opioids for a variety of reasons. And that's particularly affecting our rural communities. And this issue keeps coming up over and over again with this target population. And it's helped to spur an entire community-wide conversation about why is it that opioid addiction is such a big problem in these communities and what can be done about it. So I think actually at the end of the day, one of the most powerful things that people can do, and it doesn't even have to cost you very much money, is to actually empower individuals at the point of care to transform it. So what are some lessons learned from New York and our experiences? First and foremost, I believe at the end of the day, the cost curve can be bent, but that success depends on stakeholder buy-in. We invested heavily in the early stages of our process, getting stakeholders around the table. Not only did we have this team, but we crisscrossed the state, held public hearings, invited ideas, 4,000 ideas in fact, and that helped to generate a consensus or near consensus around a pathway forward. Second was that delivery system transformation is difficult, but the best path forward is to try to create integration and incentive alignment. In essence, my favorite phrase on this is we want to make healthcare a team sport. It's no longer a bunch of individuals doing what they can within the confines of their four walls, but actually thinking about healthcare more broadly as a team. Next is don't define the system too narrowly. Embrace the social determinants of health. Embrace the fact that at the end of the day, individuals who are the highest cost from a healthcare standpoint and most challenging to the healthcare delivery system have needs in many cases that transcends healthcare. You need to collaborate with other organizations in order to address those. And then next is the system transformation will only occur if you actually change things at the point of care. You can have every CEO of every organization in the entire country on board with a path forward, but the folks who actually are at the point of care, the physician sitting across from the patient in the exam room, the emergency room doctor who's doing triage, or even the nurse who's there working with the patient on discharge planning. If those individuals aren't engaged, if those individuals aren't empowered, if they're not part of the solution, you will find it very difficult to achieve results. And then lastly, data. Data is essential in order for folks to know that they're doing the right thing. In order for them to improve their processes, they need to be able to see their results. They need to know whether what they're doing is successful or not, and if not, what else to do. So that's it. I know it's a lot of information in a short time, but there's a lot more on our website, and I look forward to further discussion. So thank you.